show you some videos. As I think this is very important to do. Okay, so here it's very important to have this endoscopy because you really want to show and see that you don't damage there anything, and you can see it from the outside. So this is a very important point, and you have heard this before. We always perform our first endoscopy with the first prototype. We don't do it before. So we just do it with, of course, prototype because we want to do as less endoscopies as possible. So this is we really wanted to do. So maybe you have seen this before. We have a portable device. So it's possible for us to do it wherever we want. So, but we usually do it in our room with emergency equipment around, but it's portable, so you can go to the patient if it's necessary to do. So maybe sometimes in intensive care or so, it's easier to go to the patient. So we use this device, and yes, we have a checklist as well. So we usually talk about parents about this procedure, and we changed it a little bit because at the beginning we always do it on our own, and we send them out. And but sometimes they are asking if it's possible for them to be with us. At the beginning, it was a little bit scary to have them there because it's not always very nice to do that. You have experienced that before. But at the moment, we ask parents if they want to stay or not. So, and if they want, we let them in. Yes, we have this emergency equipment, and usually we perform it after fasting for 1 or 2 hours so that they are not vomiting during the procedure. And if you have another gastric tube, you can remove the residuals. And sometimes we remove the nasogastric tube, but you can still, that's a tube inside. So, and you've shown it very nicely. We swallow the baby as well as you did it. So, yes, and we always have a little bit of discussion why we do it without sedation. So, and believe me, you have heard that we train a lot of our consultants to perform that, because if somebody of us is not available, so it must be able that somebody can take over. And so, and even if somebody is coming into the team, a new team member, we always discuss this first, because they always think, is it possible to do sedation? It would be nice that the babies would not cry, but usually it takes 1 or 2 minutes. It's not too long. And even if you really want to do an IV access, it takes longer to do this IV access than to the endoscopy without. And if you have sedated infants, the muscle tone is different. So, and we really would like to see it with a normal muscle tone. That the position of the spur is very good, and it's very quick if you have done it a few times. So, and sometimes we use this classification, but believe me or not, we don't use the classification. So I will show you what we really want to see in the first endoscopy. So, when we perform an endoscopy, I think the first we insert our endoscope before we insert the palatal plate, because we really want to have a look if there are other malformations. I will show you some videos, so maybe you can have a look at it, and we really want to see are there other abnormalities maybe. And then we really want to know, but we don't change our management. I just want to say that we really want to know, is it a normal one, a normal infant with this typical, the posterior, the tongue touches the posterior wall, or is this a circular obstruction? But we really start with a normal TTP. We never change the beginning, so we just want to know it. So, and then we insert the plate, as you do very, very nicely. So, and then we have a look at the length, the inclination, and the shape of the spur. I will show you. And before I remove my endoscope, I really want to have a look in the area, in the upper area where usually the cleft is, the soft cleft, because I really want to see that there is enough space for the tongue, and then and there's enough space in this area as well. So, and maybe you have seen these videos before, but I think in this video you can really see that there is an obstruction. So at the other side you can see the base of the tongue here, and the posterior pharyngeal wall, and if you insert the plate, it looks completely different. And it's much easier to do the endoscopy if the plate is inserted, so you can see something. If you can see something, it's very good. And so you can see the erected epiglottis in the down there. So, and I just want to show you a lot of video examples. Maybe you can see that. So this is a view you usually have. This is an original version. And it's not easy to do it because it's so fast and you have to look at it. So at the beginning, there was no plate inside. So this is the version without the plate and you can see anything. And then you insert the plate and then you can see something. That's the first point. And this is the next case, 1 month old. We had to do it with with CPAP. Sometimes it's not possible to do the endoscopy without CPAP because it's so severe, the obstruction. So this was with CPAP. And with a tube, you can see. It's the base of the tongue, it's the white one. So, and we start with antifungal therapy afterwards. So, and you can see the spur. Maybe it's, what do you think about the length of the spur? Would it be a little bit too long? Because this is the area you really have to look at because it's very sensitive, this area down the vallecula here. So it's very good if it's not too long in this area. So next video. This plate is inserted. And that's real life. So what do you think about the It's too long. Yeah, absolutely. It's too long. And maybe it's not steep enough. So maybe you change it. And usually you can hear that. Maite said before that we always use a little bit the spur a little bit longer than shorter, but you can hear if you insert the plate as the patient is, then you know it's too long. So. Sometimes we remove the plate very, very quickly and not have a look at it because you can hear if it's too long. So, yeah. This is the next one.
It's a both work of the eye and the ear. Yeah, and the finger for the pressure. All the senses. Yep.
You can see that the area is obstructed there.
I think it's maybe okay. So in this case, I would have a look at it. So if it was like this, I would say, okay, we try it. Yeah, maybe it's a little bit too short, but sometimes you just have to try. I don't want to have it too long. So even if you have to decide it's too long or too short, then I would choose the too short because it can't damage anything there. And maybe you can have a look at it. So, but I have a video where you can see it's too short, then maybe it's necessary to have it a little bit more longer. So it's very, obstructive there. And this is one case. Yeah. So in this, you can see. So it's too short, and you have seen at the beginning. You maybe it's fine. So at the beginning of the video, but it's so important that you ask a co-worker or your orthodontist, is the plate in the right position? You always have to ask that. It's extremely important that the plate is in the right position. And if what you heard before, it's extremely important that the head is not overextended. Sometimes our infants with Robin sequence, they are lying in the back overextended. And you have to have a look that it's not, you mentioned that before, so it's very nice. So we always check it. So if you do your endoscopy, I think it's very important to talk to each other. So is it right? Is it plate in the right position? Is the head in the right position? Because when I perform my endoscopy, I'm so extremely focused on seeing on the screen what I have to see, because I really want to have it just a few seconds or very short time, because as somebody who has to do that, I really don't like to do that. So I really want to have it very short. Yeah. So, and as I mentioned before, I think this area is very interesting as well, because sometimes you inserted your plate and the obstruction is gone, but you can hear something when the patient is breathing, and something like a snoring. So the old person snoring, so like that. So, and it's in the upper airway. It's usually in this area here. And so it's very important to have a look at this area when you remove your endoscope. So have a quick stop at this area then and just have a look at it. Sometimes you can see there's enough space for the tongue, or it's not enough space for the tongue. And if you have problems with drinking, for example, it's a good thing to have a look in this area as well. So, but you can see this from the outside. If you insert your plate, you can have a look at this area just looking into the mouth. So, but you can have it from both sides, from the outside and from the side from the endoscope. So, and I want to show you some other aspects. So this was a 2-week-old infant admission with suspected RS. You know, if you're doing Robin sequence, maybe you know that every patient with some kind of is transferring to your hospital. So it's the same with us. So, but this infant has only mild retrognathia and glossoptosis and a median cleft with severe dyspnea. And the sleep study wasn't too bad, but this baby has so severe dyspnea. So, and we perform our first endoscopy with a prototype. You can see this epiglottis there. And we inserted our normal plate. And as you can see, it was not very good. And this is a problem in, I see you see this epiglottis isn't normal, so it looks very strange. So, and this is the patient, and so as you can see, we inserted our plate. He has high flow in between as well, and these are the mamillas. I don't know so it's not in the right position, and the baby has so severe dyspnea with the plate, with everything. And then we perform an X-ray, and as you can see, that it wasn't normal. So we had a syndromic one with short rib polydactyly syndrome. So yeah, and it's very challenging to do to produce a plate for this infants. And we sent them home without a plate, with high flow, and without a plate. So we change it if we see it's not working. So sometimes you need something different. And I've heard that you had a child, or Kelly told us that she had a child with Francis-Petty syndrome as well. And they are very challenging sometimes. This was one of our infants. So this is a picture from a paper, but our infant looks like that. And this is the endoscopy. And maybe you can see what might be a very great problem. So you can see that it's so circular, the obstruction. You can't see anything there. So, and in this case, it wasn't able just to use the plate, just the plate. We added with high flow as well. Yeah, another case. 1 week old with suspected Robin sequence. Clinical findings are only mild retrognathia. It doesn't look like a Robin sequence infant, but it's extremely severe apnea, and the baby needs CPAP. And the sleep study shows very abnormal sleep study. And this was the endoscopy. And we had and we were waiting with our prototype, but we were very surprised what we see there. Yeah, there's a cyst at the base of the tongue. So it wasn't a robust sequent infant, it had a cyst. So the surgeon came and everything was over. So this is what I meant with you have to look if there are other things you may find a part of robust sequence. So, and usually, we really don't want to do endoscopies. I really don't like it. So if you change the spur and you don't change the length of the spur, we don't do an endoscopy. So we just insert the plate and have a look if it's working, because it can't be too long, because it just can be too short. And the other thing is, if you have no new clinical symptoms, if you insert your plate and the baby is drinking well with the plate, and after a few days, the baby has fever or don't want to drink anymore, then maybe it is a good idea to have a look at it. So this is the case you have in my babies. It was a 2-month-old infant with severe apnea, and we started with our treatment. And after 1 week, the baby has increased elevation, and the baby don't want to drink anymore. So this is the endoscopy. As you can see, maybe this white area in the vallecula. So there's a pressure mark in this area, and this is what you really want to avoid. So this is a reason why we perform endoscopies. And so this spur was too long. So, and if you come to your ward in the morning and you insert your plate in the afternoon and you come in the next morning, so it's very important to hear what the nurses said. So is it well? Are there any noises, respiratory noises? Because you can have an idea where the problem might be. How is it feeling like if you insert the plate? How is the feeling with it? Is there leverage or a lot of pressure? So maybe maybe it's too strong. Or what is with the feeding behavior? If you insert your plate, it's always that even if they drink very well before inserting the plate, it comes down for a few days. And you have to talk with parents about that, because they're very worried about that. If the baby drinks 50 milliliters and after inserting the plate, the baby don't want to drink for 2 days. So they have to be prepared for that. Yes, and of course, if we are completely unsure what to do, sometimes we perform a sleep study to have a look at it, how it changed at the beginning and with the TTP. So, and I think this is very important if you're not if the plate is not very good working. So, what is the reason and what can you do? If you have these snoring voices, like these sleep voices, so maybe you have a problem in the upper area. So, and if you have an improvement of your breathing with doing ESMAC and your plate, and then maybe it's not steep enough, so you can use make the spur a little bit steeper. And if you have a syndromic infant, maybe you have seen it before. That's the reason why I told you that if you have a share 4 obstruction with a circular obstruction, maybe you can add your usually normal TTP with high flow as well. So maybe it works together. So and you can send them home with high flow in the night, maybe. Yeah, I think this is very helpful to use. And yeah, thank you so much.